Good afternoon, all the faculty members, participant attending this CME. Uh, I would like to thanks Department of Anesthesia, my senior friend Professor Vardhan and Dr. Ankita for inviting me to give me opportunity to share my thoughts on hemorrhagic shock and the topic blood component blood substitutes. You must all dealing hemorrhagic shock in OT or ICU or in emergency. So whenever we have a hemorrhage, whether we are in OT, ICU or emergency, and patient is in shock, means the blood pressure is low and patient have tachycardia and leading to hypotension. Usually the treatment is giving a lot of fluid and this all excessive fluid means in Western world they don't give more than 1 liter of fluid uh, whenever patient coming or patient having shock because this excessive fluid leading to coagulopathy, cysts or multiple organ failure and that lead to immediate or early mortality in these patients. And, this is one of the part of the adverse management that usually people do in clinical practice because this is a part of lethal triad means if you give excessive fluid it will lead to hypothermia. A patient in shock, the acidosis is already going on, metabolic acidosis, and the hypoperfusion, the hyperfibrinolysis, and thrombomodeling, or the coagulation, lack of coagulation system, or disbalance of coagulation system lead to acute trauma coagulopathy, and this lethal triad is responsible for early or late onset death in any trauma, any shock patient, I will say, because of hemorrhage. So we know this table, and according to this table of hemorrhagic shock taken from 10th edition of ATLS, that class 1 shock when the blood loss is less than 50%, we don't have to give blood product. But definitely, the class 2 shock, the patient can have only tachycardia. Class 1, patient don't have any symptom. Class 2 shock, we don't have to give blood product, but class 3 shock is established shock when the blood loss is more than 30%. Patient have tachycardia, and you find any patient when the blood pressure is low, this is the patient who is having grade 3 or 4 or more shock. Means any hypotensive patient because of bleed in OT or emergency or in ICU, this patient is having grade 3 or more shock, category of shock, and here the treatment is giving balanced hemostatic resuscitation in which the major part is blood product. I say please note down blood product, not the PRBC alone. And even we have to start massive blood transfusion, so we will discuss it further. I'm saying we are here to manage patient of hemorrhagic shock and we have to avoid lethal triad. Matlab, we have to avoid coagulopathy because of giving excessive fluid, or don't giving the balanced hemostatic resuscitation means we know the blood is not not IV fluid, because whatever we are giving it should be equal to blood. I will discuss this later on. So we should avoid this lethal triad. So if you are managing blood pressure in a hemorrhagic shock by giving excessive fluid, means 3 liter, 4 liter, or even more than 1 liter. So because you want to restore the blood volume, but this fluid is not will stay there and it will go out from the body in the next 1 hour. So this pani or yo-yo type of resuscitation is not at all good for this patient, because if you give fluid, excessive fluid will dislodge the clot, it will dilute the clot, it will produce hypothermia. So you want to increase only blood pressure or you want to restore the blood volume, or the blood product means the coagulation factors. So what intervention anybody can do for managing hemorrhagic shock means definitely stop the bleed, whether it is in the emergency, whether fracture limb, whether bleeding wound, whether a patient bleeding inside the cavity in the chest and abdomen or the bones, we have to give early OR OTSS. And here the role of anesthetist and surgeon, that we have to stop bleeding that is inside the body, because inside bleed doesn't obvious outside. Obvious bleed outside we try to stop by direct pressure or by tourniquet. Sorry, I have a URI, so voice may be issue. So damage control, resuscitation and surgery is the goal. And role of anesthetist or intensivist or clinician is in balanced hemostatic resuscitation, giving hemostatic agent, or doing early angioembolization. Means is that the water tap, आपके घर की सारी टंकियां खुली हुई हैं और आप अपने घर में मोटर से ऊपर वाली अपनी घर की बड़ी वाली टंकी भरने की कोशिश कर रहे हैं और नीचे सारी टंकियां खुली हैं। मैं समझ सकता हूँ, आप समझ गए कि पहले हमें अपने घर की जो खुली हुई टैप्स हैं उनको बंद करना है, फिर वो जो घर के ऊपर की ओवरहेड टैंक है वो भर पाए। यस, so we have to understand the concept of damage control resuscitation. Means to, we don't want that patient have global hypoxia and metabolic acidosis that lead to organ hypoperfusion and that can lead to multiple organ failure in a bleeding patient. Here the role of damage control resuscitation, we have to decrease blood loss, we have to increase oxygenation, and we have to prevent the lethal tragedy I have discussed. So permissive hypertension, hemostatic resuscitation and damage control surgery are the goal for damage control resuscitation. So we have to target blood pressure, we have to give restricted fluid, we have to give early blood product, not only PRVC. So, and we have to manage ionized calcium level, we have to prevent acidosis, and we have to take care of hypothermia, use early intervention radiology to stop the bleed where the vessels are bleeding and it is not accessible. Like nowadays, no for splenic or liver tear or the surgery is done. It's angioembolization and transfusion. Transfusion, not only PRVC. So the damage control surgery that any bleeding patient will go OT for, stop the bleed, pack pack the abdomen. After packing, send the patient to ICU. Let the patient stabilize hemodynamically, metabolically, hemostatically, biochemically, and when the patient restores in ICU, again patient will go OR OT for further definitive surgery. So now means no definitive surgery or prolonged surgery in unstable patients. And again, after stop the bleed, during surgery, patient go to the ICU. So this is the concept and how the basic management in any hemorrhagic shock patient is ABCD approach. A means if patient is shock, means grade 3 or more, intubate this patient, and because we want to oxygenate and ventilate patient, and only high flow oxygen can be given by intubation and ventilation, and we can set the FiO2. Means A and B is managed. C is a circulation and hemorrhage control, means we have to secure to wide bore IV line so that we can give high flow of fluid up to 270 ml per minute by or by gray or orange one. So 200 to 270 ml per minute fluid or blood product if needed. So we have to give only 1 liter of ringer lactate or normal saline. Yes. Why? Because we are not giving excessive fluid or only fluid. We are giving the blood product. So here the role of cross match or saline match blood product, because we know that O negative blood product saline match can be available with the help of transfusion medicine friends, and we can give it immediately in OT or in emergency. And we can start the massive blood transfusion protocol. And I thanks in SGPGI my friends, transfusion medicine guys, those help us whenever we are in crisis and patient's life in danger. So call for help means we should act as a multidisciplinary team, whether we are in OT or ICU. The blood product, definitely we know that everybody gives this red bag, and this red bag is stored blood, and it It is given only to increase the oxygen carrying capacity. But it is stored blood. The hemoglobin will release oxygen only after 24 hours. The 2, 3 DPG and other things are there. And this red bag of PRBC doesn't have the plasma coagulation factor and the platelet. So this all bag are not same. The FFP, the cryo, the the platelet and the PRBC. So we know that oxygen carrying capacity in stored blood is a questionable immediately. But if in patient is in shock, we have already intubated, we are ventilating, the fraction inspiratory oxygen I can set is 100%, means PO2 is in our hand to maintain. Its main thing is that the fluid we will give ringer lactate or normal saline 1 liter. If more than this is needed, patient is still in shock, then would we give in bolus with the fluid response, at least passively against test. The aim is we can achieve a systolic blood pressure of 70 to 90, not 90. Yes, below 90. That is called permissive hypotension, and mean is not 65, up to 50 to 65. Recent studies shown that during this range, 70 to 90 or 50 to 65 mean, all organs can be perfused well. So if you increase suddenly BP less more than this, the clot will dislodge and the bleeding will increase. So no proven rule of inotrope and vasopressure. You are increasing blood pressure on the cost of severe vasoconstriction by giving vasopressor, or you are increasing inotrope and chronotropy of heart and increasing cardiac output. What how these drug will do? If work if there is no intravascular volume, if preload is less and you are increasing afterload, whether this will be beneficial? Not at all. Role of colloid is a big controversy in a bleeding patient, because all colloids they encircle the coagulation products, the coagulation factors, and this increases bleeding. They can restore the blood volume. So definitely we have to avoid overload, and we have to take care of dilutional coagulopathy and hypothermia. So it's very debatable inotrope vasopressor to achieve a blood pressure, because blood pressure is not restoring the intravascular volume. The resuscitation goal, definitely stop the bleed, and balanced hemostatic resuscitation means achieving a mean of 50 to 60, heart rate less than 100, temperature more than 35, hemoglobin up to 7, and platelet more than 50,000 INR less than 1.5, and fibrogen more than 200, the pH more than 7.2, and ionized calcium more than 1 to 2. I always give all patient tranexamic acid and ionized calcium to keep 1 to 2 and take care of metabolic acidosis. So we are taking care of lethal triad while we are trying to achieve these goals. So the management, we want to, by balanced hemostatic resuscitation, we want to restore intravascular volume with blood products. We want to maximize oxygen transport, and we want to correct coagulopathy. And for that, we have to give early blood product, the coagulation factor, the FFP, the platelet, and when the bleeding stops, then we will give RBC to achieve a trigger of 7 or more if it is a cardiac patient. So management, the surgical management is not replacement of medical management. Means anesthetist and surgeon should take this patient as soon as patient early to the OT without any hindrance. Only blood grouping and cross matching is needed, and no PAC or unfitness. And here the role of intervention radiologist to stop the bleed, because all surgery we can't stop all type of bleed, but by minimal invasive intervention radiologist can stop the bleed that is not easily accessible. So we should achieve this massive transfusion protocol in these patients. And as per the local our protocol, because we have to administer, I will say, all three things: the platelet, FFP, cryo, and PRVC. Not only the, so if we see the blood product, I will last touch in the PRVC. The FFP that have the fibrinogen and coagulation factor, it to be initiated first. If you are doing point of care coagulation test like TAG or ROTEM, then the graph will itself show in 12 to 15 minutes that first we have to give FFP, then we have to give cryo because they increases the fibrinogen and factor that is not there in the FFP. Means FFP has all coagulation factor 8 and 8 9 and one minute factor. So for that, if we have first given 10 to 20 ml per kg of FFP, the dose is 10 to 20 ml per kg for most of the blood product. So the bag comes into 250 ml per unit, and they increases around 7 to 10 gram per deciliter of fibrinogen and 5 to 7% of coagulation factor. So if bleeding is not stopped by giving FFP, then we should give cryo. And cryo, they come in 40 ml, the dose 40 ml per unit, and they increase the fibrinogen 10 to 15 milligram per deciliter. The fibrinogen is much higher here. So after giving these two things, if we see the bleeding is not stopped, besides the other measures, then the roles of platelet, and because we know that the dose is 50 ml per unit, and it comes in a 50 ml pack, and they increase platelet by 5,000 to 10,000 in a random donor platelet. If we have the SDP that is only electively prepared, then up to 50,000 of the platelet can be increased. The aim that we should achieve a platelet around 50. So after FFP cryo, the third thing to be given is the platelet. And if by this or fibrinogen concentration, if cryo is not available and bleeding is still more, we because we have to achieve fibrinogen more than 200 gram in a patient. So factor 7 is a theoretical role, but definitely when you have achieved balanced hemostatic resuscitation, you have stopped the bleed, surgeon has controlled the bleed, then if now whatever I will give will stay in the body, and here the comes the role of your red bag, that is PRVC, and what trigger you want to have, it's already discussed in the previous lecture, but definitely if it is more than less than 7, then we transfuse it. Now it's coming to 300 ml per unit. The bag, it increases the hemoglobin 1 gram per deciliter or hematocrit 3 to 4. So my sincere request, give first the coagulation factor, increase the fibrinogen, increase the platelet, and once the bleeding stops, then definitely think of oxygen carrying capacity, because PRVC alone doesn't have, and the coagulation factor. So now the worldwide the debate is going on whether we have to come again on the fresh whole blood, because World War experience, because that has everything. But nowadays we are in an era that now we moving, going back is good, or because all the, if you ask for whole blood, you will not get it, because component therapy and component separator is always everywhere. So clinician is thinking worldwide that definitely when we have to give and take care of coagulation first, then the debate is going on from the whole fresh blood or component therapy. Then definitely, if component therapy you have, then worldwide people are using coagulation factor platelet first as compared to the taking care of this as compared to the PRVC. So the target, definitely we have to achieve INR less than 1.8, hemoglobin more than 8, uh, and platelet more than 50,000, and calcium. Very important. I will say, if you do ABG, protein, all patients have calcium less than 1. Bleeding patient, calcium is consumed for activation at every step, extrinsic, intrinsic pathway. So try to, because one ampoule you will give calcium carbonate, it will increase calcium by zero point 0.1. And all patients have lack of ionized calcium during bleeding. So try to achieve it normal 1 to 2. So massive blood transfusion, definitely we need in a pack of 4 to 6 at a time. We order everything combinedly, means 4 to 6 FFP, 4 to 6 cryo, then 4 to 6 PRVC, and 4 to 6 of platelet uh, each time. So massive blood transfusion, what is this? This is more than 10 unit of PRVC in 24 hour, or 5 to 6 unit within first 4 hour, or ultra massive transfusion means more than 20 unit PRVC. So the definition can be anything, but to start this in your institute, you have to work with team with the transfusion medicine doctors, and even the you need in what time they will that it will be transported to you in OT and ICU, because if they have given a product is not reached to you, and you should have the things to prepare like cryo and FFP, because this is coming like ice cream. So we have to trigger plan. You should have the teams who will do different work. Give tranexamic acid as soon as possible to all patients. Test hourly that you are achieving the coagulation, because just giving and not seeing what is the effect is not good. Transfuse to the target. Temperature management and terminate the code. This is the massive transfusion. T is that to be taken care. So this is one of the best drug, I will say, used worldwide. All OR, OT patient or ICU or emergency patient, if they are actively bleeding, within 1 hour, 1 gram, 10 to 15 milligram per kg loading dose, because this is a clot stabilizer. Very cheap drug. Very less chance of anaphylaxis, or 0.03% chance of thromboembolic phenomena. So if we have to decrease blood loss, we have to use it. And lot of study, don't need to do any study for this only. So all worldwide, all patients will receive within first hour of hemorrhagic shock. So we have to give it blood product, as I have said, that massive transfusion protocol you have to discuss and plan in your hospital. And within 1 hour of giving the blood product, we have to see that if you don't have the tag, definitely if you request with your pathology guys, they can give you the INR platelet NHV within 30 to 45 minutes. And besides this, do the ionized calcium, lactate, and fibrogen. So you can know what you have given, what is the effect of that. You have to give more, and what component you have to. And definitely in India, India also hypothermia occurs because patient in shock, low perfusion. So take care of hypothermia because it increases the bleeding. So treat actively by active and passive methods this hypothermia. A slide about blood substitutes. They are more in research, not available in India, but they are the product like perfluorocarbon that carry the oxygen, or these products they uh, they become like oxygen carrier. So definitely this use in Western world in war, in military settings, but in India we don't have this. So don't I think there is no benefit of discussing this. So overall, in summary, hemorrhagic shock is the principal cause of death, and it needs a multidisciplinary approach. Early aggressive care with reducing complication of hemorrhage should be considered. Damage control resuscitation means don't do further damage by it's my way of resuscitation. And we think of damage control surgery, we need teams to 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 apply it. Balanced hemostatic resuscitation means intervention designed to restore intravascular volume, means blood component, and to maximize oxygen transport. In severe hemorrhagic shock, we have to give first the stop the bleed. If patient needed OT, then it needed to be stopped in OT, whether orthopedic surgery or the neurosurgery, or the chest or abdomen to be open. Medical management give first FFP, then cryo simultaneously. If bleeding is not stopping and you don't have anything, then platelet. And later on, when bleeding is stopped, then definitely PRVC as per the trigger, means if hemoglobin is less than 7. And with this, the radiological and surgical interventions, like intervention radiologist can couple, means hybrid OR is the choice, especially in trauma bleeding patients. Means one OT where intervention radiologist and general surgeon will work together. The trauma surgeon will work together to stop the bleed. And we should establish protocol and practices to manage the hemorrhagic shock. Thank you so much. And I hope uh, my talk will, it's my views that come from the researches and my worldwide experience uh, for this hemorrhagic shock based on recent reviews and protocols will not hurt to anybody. And I welcome for the questions and thank you for patience.